Hello, everyone. Hello, everyone, and welcome to our August webinar. We're going to give everyone just a minute or so to get logged on, and then we'll get started. Going to give it just one more minute, and we'll get started for today. All right. Well, we'll hopefully continue to have people logging on this morning, but I want to welcome everyone. My name is Rhonda Fisher. I am the clinical program lead for the AHA team training program. And we want to welcome you to a special edition of our monthly webinar series. This month, AHA team training is partnering with the Patient Safety Initiative to present Improving a Culture of Safety through Teamwork and Communication, TeamSTEPPS implementation stories from the field. We're super excited. It's going to be great today. But before we dive in, I'm going to go over some quick rules of engagement. So you can access audio by listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom to switch to either find phone audio or computer audio. Please note that you will be in a listen-only mode throughout the presentation today. We'll be moderating a Q&A session at the end with our speakers, so if you have questions, please chat them in throughout the presentation. If it's a technical or logistical issue that you're having, we'll answer that question in the moment. But if it's for our speakers, we see those questions coming in, and don't worry, we'll save those for the end. So finally, please do note that this presentation is being recorded, and we'll notify all registrants when the recording is up on our website. Now, continuing education. We know that it takes a lot for you to give up an hour of your day, so we're pleased to offer free CEs for our webinar. However, in order to claim your CE credit, you must create a Duke OneLink account. This is a one-time only setup. My colleague Kara has chatted in those instructions, and you can also refer to the email that we sent you this morning. It has the information as well. What you're going to want to do is, following the webinar, you're going to text that code that you see on the screen, DUQBES, to the number that you see on the screen. And don't worry if you don't get that all right now. We're going to share it at the end too. All right, so we are pleased to introduce you to a phenomenal panel of presenters for today's webinar. I'm going to do just a quick introduction here. We have Lauren Schiff. She's the Associate Chief Medical Officer of Quality and Safety at the University of North Carolina Medical Center. She's joined by Christy Dangerfield, the Patient Safety Officer for UNC Medical Center. And then from our partners at Northwell Health, please welcome Terry Dillman. She's the Chief Nursing Officer of Northwell Health, Plainview Hospital, and I hope I say this right, Syosset Hospital. And then we also have Denise Mazapika, the Clinical Program Manager of the Institute for Nursing at Northwell Health. So, love it. So, moving on, our objectives for today. So our hope today, our goal is to showcase TeamSTEPPS as the framework to improve teamwork and communication to impact patient safety culture. This is aligned with the AHA's Patient Safety Initiative. We're going to highlight successful TeamSTEPPS implementations at UNC hospitals and Northwell Health. By doing that, we want to demonstrate for you the improvements in the culture of safety through data and storytelling. And then finally, we'll introduce AHA team trainings offerings, including the resources that are available to you, our regional trainings, our custom advisory services, just to showcase how organizations can enhance teamwork and patient safety through the different options that AHA has to support you in that work. All right, so going to get going here. Of course, my screen is not moving. Okay, so as we get started, I'd love for y'all just to take a quick, deep breath. Maybe even close your eyes for a moment, because I want you to paint a picture in your mind. What would it be like if you had a strong culture of safety embedded throughout your organization? Imagine achieving excellence in both patient safety and clinician resilience, despite the workforce challenges that we face. And then finally, think about what it might look like if you transformed your group of experts into a truly expert team. Now, I want you to think of all these things together, and I want you to position them underneath one underlying truth. It's possible. It's possible. With TeamSTEPPS, you really can improve the culture of safety at your organization through strategic and tactical teamwork and communication training. I want to tell you, the picture in your mind that you've had can become a practical reality. We're seeing it happen all over the nation. And honestly, pursuing these things, it needs to be a non-negotiable, because as a nation, we know that we're still struggling to get a grip on our healthcare delivery and patient safety challenges. Just quickly, the Joint Commission just released the 2024 Sentinel event data, and Sentinel events have reached an all-time high, even greater than during the COVID-19 pandemic. And at the heart of all of these Sentinel events, there you see on your screen, top 3 causes: failure to communicate clearly with our teams, failure to establish a shared mental model in our plans of care and in our courses of action where our patients are concerned, and then a failure to address the human factors at play when caregivers knowingly or unknowingly neglect to follow policy. Can we do something about these things? Oh, yes, we can. And we need to. Because as much as we long to point the finger at the front line, let's be crystal clear about the pressures that our teams are under. The fires of burnout still run hot. 42% of nurses and 33% of doctors are planning to leave their jobs by 2026. Not only that, but we are flushing away 10 to 15% of healthcare expenditures on the direct sequela of healthcare-related patient harm. That's money that could be being used to help provide the physical, emotional, relational margin that our teams need to stay in the game. So where do we go from here? Well, I'd like to introduce you. If this is TeamSTEPPS is new to you, I want to introduce you to it, because we see this program making a dent in all 3 of those things on the previous slide that I just showed you. TeamSTEPPS stands for Team Strategies and Tools to Enhance Performance and Patient Safety. It's an evidence-based teamwork system aimed at optimizing patient outcomes by improving communication and teamwork skills. You need to know that it's based on more than 30 years of evidence on teams and team performance in very high risk, high stakes environments like the military, aviation, nuclear power. We took a look at those high risk industries and we said they're chasing zero harm and they're winning. Can we take what they're doing and apply it to our own high risk, high stakes environment and start moving the needle on the things that we care about most? And the answer, my friends, is yes. So TeamSTEPPS, it's not only about the program itself and the tools, it's how it supports everything else you do. You can see on this screen, we take aim at supporting just culture, psychological safety, high reliability, those organizations that consistently avoid harm in those complex, high risk environments. So it's the what if we're chasing. And we know that TeamSTEPPS is the vehicle for achieving these broader initiatives. It's not something else to do. It's going to be how you do everything else. Does it work? Does it work? Absolutely. This is just a smattering of the data. You're going to have access to this slide, but pick your thing about what is meaningful to you. Is it that your teams play nicely together in the sandbox so patients don't get hurt? In a multi-specialty physician practice that completed TeamSTEPPS training, 90% felt better equipped to manage disagreements, and 84% reported that disagreements were handled appropriately. Is it the desire to improve workforce well-being? So you shut that revolving door of staff turnover. An evaluation of TeamSTEPPS in an ICU found teamwork improved and nurses planning to stay increased from 58% to 89% in just 2 years' time. We can do this. It works for patient safety, for patient satisfaction, for workforce well-being. TeamSTEPPS works. We're about creating the patient safety culture that can change not only your organization, but your day-to-day workflows. Go ahead, Chris. I'd love to introduce you to talk about the Patient Safety Initiative.
Rhonda, thanks so much. For those who I haven't met, I'm Dr. Chris Rienzo. I joined AHA almost 3 years ago, wearing two hats. I get to be AHA's chief physician executive, and in that role, I spend about 150 days a year on the road. I'm in an airport right now on my way to Columbus to visit with some members in Ohio. And I also get to serve as the president of our Health Research and Educational Trust. But before that, I spent about 10 years in chief physician roles at health systems in North Carolina. So I have been in literally shoes just like yours, working on the ground every day on patient safety and improving outcomes. 2 years ago, AHA's board asked us to do the same thing with our field. And we went to the field. AHA is nothing if not a member-driven association. And so 5,000 hospital and health systems told us, don't make us do this new thing or that new thing. Help us really connect foundationally and catalyze, convene, and connect us, because AHA, that's what you're really good at. Out of that initial ask grew AHA's Patient Safety Initiative. And the next slide gives you a sense of how the 1,800 hospitals plus nearly all state hospital associations around the country have engaged in that work. You all told us there were 3 foundational work streams in the first year, which was last year, where you wanted us to focus. First and foremost was the culture of safety. And this ranged from helping your boards understand how that culture starts within a board and flows all the way down to a bedside, all the way through to how we engage patients and family members. You also asked us to focus on disparities in health outcomes, and specifically healthcare workforce safety. We did that through an innovation engine, which has gathered hundreds of stories from hospitals like yours who've made strides in improving this effort. And many of you are members of AHA's Patient Safety Initiative, and you've contributed those stories, or perhaps even more importantly, had a chance to learn from them. On the next slide, I wanted to give you a sense of one of the things we've produced from within that Patient Safety Initiative, and that was this particular insights report with Press Ganey. We've produced a couple of reports with our core data partners, including Vizient, but this one on Press Ganey leaned into the area that we're going to hear the folks from Northwell and UNC speak to today. You can jump to the next slide, because it was crystal clear in the data from Press Ganey that while we all had our challenges during the pandemic, and I was a CMO of a health system in North Carolina, I lived it just like you all did. Things are on the rise. But in order to keep them moving in the right direction, on the next slide, we were trying to understand, using their universe of data, what connects, what makes the link to how we feel a culture of safety on the healthcare workforce side. And this became pretty darn clear. The data speaks for itself, that when you look at health systems who within their world ranked in the higher portion on their culture of safety scores, their employee engagement was dramatically higher than those who did not rank nearly as high. And if you go to our patients, the data is equally clear. When you ask our patients, and I don't care which setting it is, because they looked at exactly the same question in inpatient, ER, OR, ambulatory, you name it. Perception of staff teamwork is number one. Does the team members work together? And if the answer to that is yes, then it drives effectively all of the other things measured by our patient surveys as well. That's why I'm so excited about this work. I have been involved in TeamSTEPPS for almost 20 years, back from when I was a medical student at Duke. And I'm incredibly supportive of the work we're doing here at AHA. I got to visit with the UNC folks while they were in their course, and you are going to get to hear from them next. So Rhonda, let me pitch it back to you to introduce Christy and Dr. Schiff.
Yes, thank you. So again, I'm not gonna take any more time. I've told you who they are. You're gonna love hearing their story. I'm gonna shut my mouth so you can hear from them.
Right, thank you so much. So I'm going to kick us off before I hand it over to Lauren to wrap up our portion. So we are from Chapel Hill, North Carolina, large academic medical center that partners with the university. Just a little bit of context as we go through some of our slides. Next slide, please. So when you ask about like why, what is our why? It is very similar to all those data points that Rhonda called out at the beginning of the presentation. We had formalized a little bit more of our high reliability journey, focusing on the elements that you see in that blue slide there, calling it our Carolina quality approach. So it kind of made sense to the front line of the work that we were doing. We started with just culture and worked through some of those elements to get really level set. And then we're like, you know what, TeamSTEPPS is next. And why we prioritize that as next goes back to some of those culture of survey responses that we were getting. So whether it was our engagement survey results, our safety cultures results, some scores were a little bit stagnant. They were not improving in the way we would want to see. Some were on the decline. Along with that, we were seeing things like the increased turnover rate or some poor retention rates that lined up with what we were hearing from our frontline team members. The other piece that came up as a why for us was seeing that high number of teamwork and collaboration issues as our contributing factors when looking at our serious safety event reviews as we were going through those, whether it was a root cause analysis or just general reviews around some safety issues. It came up as one of the top contributing factors in a lot of those events we reviewed. So we realized, you know, I think it's time, we're ready for this. This is, and that was a lot of the why we built behind it. You know, additional things looking at our external benchmarking, like not being where we wanted to be for CMS or comparing our Vizient scores were some other reasons that led to that. Next slide. So we partnered with the AHA and it's been an amazing experience, and we developed this roadmap. And so this is really what led our journey for our first year. This was the slide we shared in every report out to highlight where we were, what's next, to create that situational awareness for everyone across the institution. But we started with, you know, at the executive level, we looked at how do we cohort our groups for it to make sense of who's attending classes together. And you can see we followed the model of, you know, having master trainers train for the 2 days. And then we went into some essentials training and we rinsed and repeated that across our different clinical areas. I think something to call out is originally our plan was to start with the OR and surgery services because that's where we can tend to see more of our harm events that come out of. But we were in the middle of building a new surgical tower that got delayed, and we had to actually switch up our approach. And so just, I think, thinking as you're trying to roll out something this big for culture change, you always have to keep in mind those operational challenges that might come up and how do you pivot for those when they're seen. So over the next couple of slides, we're going to break this down a little bit more. So our next slide is going to go into that executive piece. So, I mean, we had to start here to get the buy-in before we ever brought in AHA because we needed the approval for those funds, which is important, but then also really to support the initiative because, you know, we are not going to get anywhere if we don't have that leadership buy-in. And so we worked on building a business case, looking at why is this a risk? Why is this important now? What barriers exist right now? And why, even with those barriers, it's important to move this forward. So we highlighted things like how we might be impacted financially if we do go this route, but also how can we be impacted financially if we don't go this route and we continue to see those harm events tying back to that communication and teamwork. We pulled in like how this can impact us from a cultural standpoint, how this impacts our patient outcomes, our external metrics, all of those things is creating that business case. Once we got agreement and support from our executive team, we started with that executive briefing. So it was us, the AHA, and our executive team just really getting into the weeds of what this is going to look like, how we need their support, and things along those lines. And then the other piece was really important that they attended the class. So they attended the 4-hour essentials class with all of our other teammates. And so they got to see their leaders right there with them, work with them at the tables together. The picture there highlights our president and our chief operating officer at their TeamSTEPPS class with the frontline staff that do the work every day. And so once they went through it, it became this even more of a powerhouse because they were even more like, it was amazing. It was, and then they started, role modeling the tools, the language and things like that. So it was a stepwise approach to get that full buy-in so they can help support us with the cultural shift by role modeling the behaviors as well. The next slide talks about kind of the middle section. So I just highlighted the front end of the executive work, and we wanted our leaders to go early on to some of these trainings. As we were looking at the 2-hour class, the 4-hour class, and who goes and how we build this, we kind of looked at it by, going through like these 3 Ps. What is our purpose? What is our product? And who are the people? And so we did some different cohorting of who we wanted to go together. So we tried to group together the teams that worked most frequently together, that had that cross-pollination of, we have a medicine service line, but they get a lot of patients from the ED. So here's a good opportunity to partner them together to go through this training. So these areas would identify some people to attend the master training session. And then that next 4-hour essential session was then targeted to that same cohort. So medicine, ED, women's, children's, and psych. You'll see the call out there is we prioritize leaders. So we had our master trainers that were developed and we prioritize those seats to our leaders. And we use the term leaders loosely because might be your formal and informal leaders. So it might be your charge nurse, your director, your executive medical director, all mixed into there, like the leader that's going to help champion this for your area was kind of the goal there. So we prioritize those seats for those people first. And then as there were additional seats open, we kind of opened it up for anyone else to sign up for those opportunities. So we were able to fill all of our seats across all of our offerings using that model. Our goal with this, like the purpose was we wanted to build the resources, so build the master trainers, and then they came back and would help us teach those essentials courses. So then it was continuing to learn and build that strength. So then they could go back to their local level and potentially deploy some training there, or look at how can we embed some of these tools into our local areas. And so that concept is what we followed across our implementation process. The other thing to call out, like when we looked at this model here, is the first group, the master trainers, really helped develop our content. So we used them to help us build what is important. They just experienced all of it from the master trainer and 4-hour essentials. They helped us build then what is going to be our core curriculum for the next couple rounds that we went through. And actually that's the same core curriculum that we teach today was what they helped develop. They're the ones that said the priority is this is in person. This is not a WebEx option. So hearing that from the people that went through the class really strengthened how we built our program as we continue to move forward. And they were a huge part of that. Our next slide. So I'm going to turn it over to Lauren to highlight some of our early wins and some of our aha moments as we went on this early journey.
Thank you, Christy. So we were really, really surprised at how many quick wins and early wins we really had. As Christy mentioned, that first group of master trainers got so enthusiastic that they really got on board and helped us define what it is that we needed to spread to the rest of the institution. And immediately the feedback we were getting were things like, I really didn't want to go. I saw this invitation and I wanted to click delete in my in basket. But I went, and it was the best. It was so much better than I ever thought. It was the best seminar I've ever gone to. And I am telling all of my colleagues and all of my leaders that they have to go to. Um, Interestingly, recently, one of our peri-op directors sent an email to all of the people that he is over saying the same thing, saying you have to go, because I'm telling you this is the best thing you'll ever experience. And it was so meaningful to me in terms of reflecting on my practice and how I can make our environment better. And hearing that from your colleagues is really the thing that motivates us forward. Other quick wins were really having certain tools being immediately embedded into use after people learned them at the AHA Essentials training. We can go to the next slide. One that we really wanted to highlight was our patient relations office. So we think a lot of times that TeamSTEPPS is really geared clinically, but it's not. I mean, it is, but we can use these same tools in every environment, and every environment it is incredibly meaningful. So our patient relations group came to our essentials training, and to give some context, we invited everyone from every possible corner of the hospital to be involved in this. Did not have to be clinical. We had administrative folks there. We had food services, environmental services there. And our patient relations group went back and really spoke to each other and said, hey, you know what? The situation is that we are not getting feedback from the doctors and nurses that we are sending emails to, that we need responses from about these patient complaints. And the background was that, patient relations teams have 7 days to respond to CMS guideline. By CMS guidelines, they have 7 days to respond to a patient grievance in writing. So they're really relying on the folks they reach out to get back to them promptly. And they assessed that if they used SBAR in their communication with the people they were reaching out to, that they thought they would likely get a better engagement. And wow, were we surprised. They have now employed SBAR as the only way they communicate all patient relation grievances to doctors, nurses, administrators. And using that format, they have gotten an incredibly improved response rate in terms of not necessarily the number of responses, but how quickly people are responding and how generously they're responding in terms of the information and engagement they're providing. So when people respond, they're not responding defensively, as in, what do you want me to do about this? Which is often the response that people have when they're being accused of doing something that a patient's concerned about. Instead, they're getting these very thoughtful responses that are able to pinpoint exactly what the patient's concerns were and why it happened, because the way that patient relations using SBAR outlined the problem made it so concise and clear, and eliminated any of the accusatory or defensive elements that can sometimes come across when we're trying to convey a complaint. You can go to the next slide. So the next big step in this journey is sustainment, and that's where we're at right now. We had planned that the master trainers that we trained would be our embedded trainers going forward, and we would use them to train locally and to get the rest of our cohort of our entire hospital, which is about 14,000 people. We were aiming to train everyone over time, and we knew that was going to take many years, and we were willing and excited to do that. Seeing the incredible response from our own people in terms of their adoption rate of the tools, their excitement about the training, our C-suite decided they wanted to train as many people as they could within 1 year. So we have turned around, and in this year, we're using a core group of our master trainers dedicated to training as many people as we can. Now we have 18 classes per month offered throughout the time, with 12 dedicated people who, they're not using all of their time, but we have 12 people, so they have a certain amount of FTEs dedicated to that for this upcoming year. Our goal is to train 12,000 people. We know that there's a tipping point, and once we get probably over 60% trained, the extra folks is kind of like gravy, because it gets so much of a buzz in the institution that maybe we don't need to. But the more people are engaged, the more excited they are to do the work. So we are thrilled and excited to continue that. What this means is that once we reach that tipping point, whether it's 60% or the next year of training, we will have enough people in our institution who are treating TeamSTEPPS as just the way that we do business to maintain that going forward. Some of the ways we know that we're going to need to, and we are building to be able to sustain it, is identifying a core training program going forward, which would probably be a little less robust than this first year, but identifying that. And then creating a training dashboard so that there's accountability within our leaders to see who in my area is trained, who do I need to get trained, and not just training, but implementation, who is using the tools and implementing it. And so we've created a dashboard report where all of our teams come and report to our CNO, CMO, COO, what other C's am I forgetting? CMO, every month, and report in on where they're at and what they're planning to do next. Some things we're looking at to the future is building a very clear onboarding plan. Anyone coming into the institution has to get trained as part of their onboarding packet. That's already in process, but we're going to be refining it over time. And developing things like tool of the month so we can kind of do house-wide education and encourage people to use particular tools in kind of in concert. So there's like true teamwork and a true hospital narrative. And also identifying really specific recognition to, highlight where people are doing amazing work and really putting this work into place and improving our patient safety and our patient outcomes. We can go to the next slide. So our key takeaways. Be prepared to build the plane while you're flying it. That is probably the biggest understatement I can give you. We had to pivot multiple times, and that is okay. We recognize that as resources change and as Christy mentioned earlier, as new things come up, we're going to adjust. But that's the way we can make it done. If you don't just jump in, it'll never happen. Can never prepare for everything. The buy-in from executive leadership was absolutely essential, and they really went from people who said okay to people who were truly evangelizing this, and that has made the biggest difference in our institution. Having that dedicated, we had someone we were able to put in the place of actually kind of running the program, building the program, making sure we could get the trainings done, all of that work, building the dashboards around training sustainability, having some dedicated time for someone to do that is really important to keep things moving. Building examples into the training for all roles and all disciplines. This, the example we gave outside of the clinical space is just as valuable as inside of the clinical space. And when we brought those examples forward, it really, really blossomed in those other areas as well. And then as people usually see, physician buy-in can be its greatest challenge. And I can tell you as a physician, it's not because the physicians don't care. It's that because the physicians are so challenged to accomplish everything they can to deliver the best patient care they can at every moment, that unless something is demonstrated to be super high value, they're going to push away. So what we need to do in these environments is really clearly demonstrate the level of value that this program offers and improves their daily work so that you can go home happy because you had a good experience working with your teammates. And then they can't undersell the power of storytelling. We've all experienced really challenging, devastating things throughout our careers in medicine. And the more you share your story and how things could have been better, or how they were better because teamwork and communication was better amongst your team, and how you had that save, or maybe you could have made that save if you did things differently, is the most meaningful why you can give. And then finally, people obviously always appreciate good food and free parking. So if you're planning any trainings, we highly recommend feeding them well. We still hear, I heard the other day, I went to my own doctor's appointment and the CMA who had gone to the training told me the food was so good. And so we're still getting props from our community about TeamSTEPPS because of the food. So thank you so much. And we're excited to pass it over to Northwell.
Awesome. Thanks so much, Lauren. Super inspiring. Thank you so much for sharing. There are some questions coming into the chat, so we'll be sure and address those at the end. And without further ado, I want to pass it over to our partners at Northwell.
Thank you. And I want to thank you for AHA for inviting us to be part of this webinar. So we titled ours From the Boardroom to the Front Line because that is exactly what has happened here at Northwell. Next slide. So I want to talk to you about our why, right? Because that's where we all start. And we really had a very simple why. Despite having multiple patient safety initiatives around the organization, and at the time we had about 15 hospitals and long-term care facilities. Despite that, all those initiatives, we were still having adverse events. And when we looked at these adverse events and did a root cause analysis, three main things would always come up as the leading cause: communication failures, failure to escalate, and working in silos, not truly working as a team. And so we were looking for what could be a possible solution for this. And we had two main goals. The first goal was that we wanted to build a sustainable culture of patient safety and make that culture a foundation to our daily practice, to every single thing that we did. That would also help us optimize teamwork and communication. And the second goal we had was we wanted to create an empowering environment where the staff would know that not only was it acceptable for them to speak up, but it was expected that they would speak up and influence actions that would impact patient safety. So when we thought about all of this and we looked at our goals, TeamSTEPPS was identified as a solution to help us achieve our goals and to help us with our why. And here on the screen, you can see all of the reasons why TeamSTEPPS helps you to create that culture of safety. It enhances patient safety. It enhances operational efficiency. You have a real strong team dynamic. It improves communication at every level. And when you go back and you look at your culture patient safety survey and your Press-Ganey scores, teams really have a higher satisfaction once they've implemented TeamSTEPPS. You can go to the next slide. So right before I go to that, I just want to tell you that we started this in 2007. And when we decided we were going to do this, we decided to take TeamSTEPPS and pilot it at one of our hospitals. And one of our community hospitals volunteered to be the pilot. And so we had system master trainers who went to that pilot site, did master training for all of the leadership, for anyone identified as a possible master trainer, assisted with the essentials training of both the clinical and non-clinical staff, helped to create the change teams on each of the units and in the departments. And we went unit by unit. We created cohorts. Which were the teams and units that engaged with each other on a daily basis? So you might have the whole peri-op team. You might go from the ED to critical care to step-down units to med-surg. And we created the cohorts, and that's how we did the training and implementation. This was so successful. We trained the entire hospital, every single person in the hospital. We actually used to say, as a matter of fact, that if you wore a Northwell badge, you would be trained. And that's who we trained, everyone, both clinical and non-clinical staff. It was so successful that, and it was deemed a success by both the staff, the physicians, the patients, that the executives at the organizational level said, we have to spread this. We have to spread this, and we have to spread it as quickly as possible. So we actually sat down and created a standardized process for training and implementation. And it's basically what you see here. We created a timeline. We were going to spread this over the course of 1 year to all 14 hospitals, to all of our sites. So we created a timeline for training and implementation. We standardized that training and implementation. When 60% of the staff on a unit or in a department were trained, we began implementing on that unit or in that department. We didn't wait for 100%. 60% was the tipping point, as our colleagues at UNC indicated in their presentation. Prior to doing any training at a site, we did the hospital safety culture survey as a measurement. So we would do that first, and then we did 2-day master training for all of the leadership at the site, not just for people who were chosen to be master trainers, but every member of the leadership team, from the executive C-suite to the unit leadership, were trained. We then did 4-hour training for our clinical staff and 2-hour training for the non-clinical staff. We did interdisciplinary training as much as we possibly could. So any of the physicians that were employed by our hospitals were part of the unit training. They did not get separate training. They all trained together because they worked together as a team, and we felt they needed to be trained together as a team. Part of the other provider engagement we did, you all know, we have those physicians that are employed by our hospital, but then we also have those physicians who are voluntaries, right? And they have their own practices. Now, it's not feasible or reasonable to say to a voluntary physician, you have to close your practice down for 4 hours and come in to do this training. So we became very creative. We took over their meetings. What meetings did they already come in for? And we were able to take over those meetings and do TeamSTEPPS training. We did dinner trainings, okay? Because just like everyone else, if you feed the physicians and the providers, they will come. So we did dinner meetings. We went wherever we needed to go. As a matter of fact, just a quick little story. There was a group of surgeons that no matter what we were doing, they were not coming to training. So one of my colleagues and I actually went and met them in the surgical lounge. In between their scheduled surgeries to talk them to a little bit and at the end of their day about TeamSTEPPS. Because as we said, you have to at least to be able to recognize the language when you hear it. And that's how we did everything we needed to and got as creative as we could for provider engagement. And then again, as our colleagues at UNC said, storytelling. Okay, Don Berwick from the Institute of Healthcare Improvement one time said, if you use numbers to reach the head, you use stories to reach the heart. And both are equally important. And we use storytelling, and we actually encouraged, as we went to train at each of the sites, your stories. Share those stories. Those stories are going to be what makes an impact on the staff, what helps them to understand the importance of patient safety and the importance of TeamSTEPPS to help us achieve that culture of patient safety. You can go to the next slide. And we basically used this. This is the TeamSTEPPS phased approach, right, to training and implementation. And this is exactly what we did. We would go to a site, we would do a TeamSTEPPS overview for their executive leadership, for the C-suite at that site. They would then choose a TeamSTEPPS coordinator, because there had to be someone that we at the system level could coordinate with at the site level. And that was the TeamSTEPPS coordinator. Again, each site, before we actually began any training, took the culture of patient safety survey. So we had that pre-metric. And then we would sit with the system site coordinator and come up with their cohort. What group do you want to go first? What cohort is going to go first? How are we going to do it? Classes, all of the things that go into training. But at the same time as we came up with these plans, we started immediately to think about how are we going to make this sustainable? We didn't want it to be a flavor of the month. We wanted it to become part of our DNA here at Northwell. And that's why we began right from the very beginning. When we created that systemized, standardized implementation plan, sustainment was integrated right in there as well. And on the next slide, you'll see that this is just an example of our timeline. This was our timeline, okay? We did our pilot site in 2007. And then we decided, and at the end of 2007 and into 2008, and then we said, okay, let's start moving this. How are we going to move this throughout the health system? So we created this timeline for implementation and sustainment. And if you look at the one that says LIJ, which is one of our tertiary sites, you'll notice there's a break in the timeline. And that is because they were implementing an electronic medical record. And they asked us, can we just break and do that implementation, and then we'll continue on. And we found out afterwards from many of them that the TeamSTEPPS that they had already learned actually helped them with their implementation of their electronic medical record. So I'm going to hand it over for the next few slides to my colleague, Terry Dillman, and she'll take us through the next few slides.
Thank you, Denise, and looking forward to these next few slides. So, Denise mentioned earlier when we did the first pilot site, just to put the numbers into action, the pilot site, 9 out of the 11 domains underperformed the national average. And I saw a question in the chat. We did use our AHRQ Culture of Safety Survey to look at the pre-implementation data points. We did a SWOT analysis to understand where we were and then where we're going. But we built a strategy around it and looked at 5 focus points within our strategic planning. And one was our culture. And Denise said this, it was leadership master training, and it started at the executive level. So we were all speaking the same language, but incorporating it into our current practices. And I think our colleague said that, don't add on another thing. So we took this and implemented this into our professional governance model and strategy within our orientation and built a sustainability plan. You're not doing anything without your workforce and having a dedicated workforce based on engagement. So, same thing with our colleagues. We developed team member training. If you had a Northwell badge, you were getting trained. And our focus is our patients and our community. And so how did we do that? And you're going to see on the next few slides, we did storytelling and we shared success stories using exemplars, which you will see, and really holding our leaders accountable to speaking that language and accessibility and availability. Next slide. So let's show you the data. We're going to take you down some of the data from 2019 to present, utilizing our survey, our overall survey for Northwell team member and physician based on our national average. And we outperformed the domains, the overall domains for our AHRQ, prevention and reporting, pride in our reputation within the work that we do, and then resource and teamwork in action. Next slide. When we look at 2020 and 2021, that was a very hard time for all of us in healthcare, especially during the pandemic. So you look at your overall scores based on your national average, and Northwell overall outperformed, looking at pride and reputation, prevention and reporting, and then resource and teamwork utilization. And then when you go to the next slide, for 22 to 23, we track this every single year. We also looked at psychological security, teamwork, and continuous improvement models. We looked at our work year over year and based on the national averages. In 2024, we did a pulse survey, and then you don't see the 2025 results as of yet because we are doing our survey in the fall of this year. Next slide. So let's talk about TeamSTEPPS in action. And I think this is important to incorporate this work into our governance model. I will share that, we have a central CCC, Collaborative Care Council, as well as a unit-based Collaborative Care Council. But one thing that we did differently is we have an executive Collaborative Care Council to bring this to life and hold each other accountable from the executive perspective. So you'll see 4 stories in action here. You take Syosset Hospital, 15 years CLABSI free, 15 years for non-ICU. You look at peri-op and you look at the endo work. We make sure that the nurse exec and our physician chair partner in this work. Over 3 consecutive years of burn-free, our ED left without being treatment, our central lines we just talked about, and our falls with injury over 3 years, free without fall with injury. And I think that's important to mention, and I don't want you to look at the data, but sharing these stories in action. We did that on our situational awareness call this morning with our team so that they can speak the language. We also have a common board. It's continuous excellence journey boards, right? So we're all seeing this in action. And we utilize this example, right? You're focusing on communication, leadership, situational monitoring, and mutual respect. And so this is probably one of my favorite TeamSTEPPS language in action. This was a case in same day where a 19-year-old Hispanic patient came into the hospital for surgical services for a kidney transplant. The registered nurse used a translator phone just to make sure the patient was aware of, his perioperative course, what surgery he was happening, and the transition plan, as well as, his medication management. The patient said, "I'm not worried. My kidney is going to grow back." And this registered professional nurse stopped the line right there and utilized the same common language. I am concerned, I am uncomfortable, and this might be a safety issue in action. We got the team together, right? From a situational monitoring perspective, shared this. Now, we did cancel the case. Ultimately, this patient did give his kidney, right? But we needed to stop, re-educate, and make sure we had a safe environment for our patients. Next slide, please. Denise, you want to take it away for sustainment?
Sorry. So what was our plan for sustainment? Okay. As I said, we did it right from the beginning. One of the first things we did was we made the change teams permanent. And those are our unit councils, our collaborative care councils. They were the original change teams. They are now permanent. They use TeamSTEPPS, okay, to help make change on the unit. They also monitor TeamSTEPPS at the unit level, because on the agenda of these monthly meetings, on every agenda is TeamSTEPPS. How are we doing? How is it going? Do we need any redosing? They do a tool of the month. I noticed our colleagues from UNC had talked about the tool of the month. Well, the tool of the month goes out through the Collaborative Care Council. And then at the hospital level, we have what we call the Hospital Collaborative Care Council, where all the unit and department councils report in, and they talk about how are they using TeamSTEPPS best practices and the things that are going on. The other thing we did is it's part of all onboarding, right? When we looked at this and we thought about how do we make this stick, we realized that people come and go, right? Staff leaves or take another job or move. So we've got to make sure that the new people coming in get the same training as we had done originally. So it's part of new employee orientation for nursing, for support staff, for non-clinical staff, as well as the new groups of physicians come in. They do what we call here a boot camp. And so they also get TeamSTEPPS training. It's part of simulation. We have simulation labs, both here at the Institute for Nursing and at the Center for Learning and Innovation. TeamSTEPPS tools are built into that. We look at all of our policies, our guidelines, our competencies, and we build TeamSTEPPS into that wherever it is appropriate. We're constantly monitoring at the system level, and consulting with our sites as to how they're doing. We're very often asked, hey, listen, we've had a lot of changeover in the leadership or in our team in a certain service line. Can we come back and get redosed? We do that. I told you it's part of the monthly agenda, and we really do use TeamSTEPPS as the thing that we use to do everything else. It's not something else to do, it's the something to do everything else. So when we look at our units and we see what are some opportunities for improvement, we think about which TeamSTEPPS tools, since they are evidence-based, which TeamSTEPPS tools can we use to maybe have a targeted intervention for this issue and this opportunity. The one thing I have to tell you is we now say here at Northwell that TeamSTEPPS has become routinized. And what we mean by that is it is such a part of our daily routine. It's part of the daily practice throughout this health system, okay? It is not an initiative. It is not thought of as an initiative. It is part of our DNA. It's who we are as an organization. Next slide, please. And I want to just leave you with some lessons learned and some things you should make sure you don't do if you want to do TeamSTEPPS. First of all, it is not optional. The training is not optional. The implementation is not optional. We are becoming a TeamSTEPPS organization. Everyone has to get on board, get on the bus, so to speak. You have to have ongoing executive leadership and support. You cannot have it for just the beginning and then it goes away. It has to be ongoing. Your executive leadership and your physician leadership have to talk the talk and walk the walk. Okay. I highly recommend that you standardize your training and implementation process, cohorting those units that engage with each other, making it interdisciplinary. The one thing I have to say is, do not dilute your TeamSTEPPS training. We saw this happen in the beginning where, well, let's just make it part of something else that we do training for. And do we really need to do 4 hours? Maybe we can do it, in an hour and stuff like that. Does not work. Does not work. So we rapidly said, no. This is something that we have to go back to our original plan. It does not work if you dilute it. You have to make sure that people are getting the training that they need to get. And we're now actually moving on. I don't know if you may or may not be aware. Currently, we were at, I believe, Terry, please jump in and help me if I'm wrong about this. We were at something like 21 sites, but we now have just recently added 6 additional sites in upstate New York and in Connecticut to our family. And my team and I are already planning doing TeamSTEPPS training and implementation with them. As every new site comes on, they become integrated into our TeamSTEPPS organization.
Denise, if I could just mention one additional thing, out of every pillar you see here, it's important that we prioritize an organized plan for sustainment. Please don't leave today's session thinking that this is a one and done.
No.
Having a culture of safety, it is so important that you have it. You build the program, you have it in orientation, you build a sustainment plan that's ongoing, not just refreshers.
Right.
That's the key to the outcomes that you saw on the slides that we presented today.
And one other thing that I wanted to add is that we also do what we call internal master training. We do once a quarter. So whenever new leaders come in, new staff come in that need to get master training, then they come to at the system level, and we do a master training for them. So training is always ongoing. Training and monitoring, as Terry said, that's how you sustain. That's how you make it stick. And that's how you get ownership of it, not just buy-in, ownership of TeamSTEPPS. And thank you for listening to our story.
Thank you
I
so
don't want
much.
to cut in because I could listen to these 4 ladies talk all day. I really could. You guys are amazing. I loved hearing your stories. I love hearing what's newly going on at UNC and what's continuing to go on strongly at Northwell. We've had lots and lots of questions that have popped into the chat. We've been answering them. We see how I take credit for not what I did. Your panelists have been answering those questions in the chat. So thank you for that. Have a look. If you hadn't had a chance to kind of review those answered questions, take a look in the chat. So just quickly want to let you know that, Kara, okay, we have yes. So I'll just do a verbal. I see the slides are off. Letting you know that we will be sending you some follow-up. So any questions that you are just dying to get out that you feel like didn't get answered, please do pass those on to us. We'll get that information from your panelists and be sure to get back to you. We will be sending you some resources on TeamSTEPPS. We'll let you know where you can go get courses across the nation. We will let you know some information on custom advisory, having us as AHA faculty come to you. Just want you to know that the ladies you see here on the panelists are also external faculty for us. They go and teach at your other organizations. So fabulous. And let's see, I probably have 30 seconds left. So thank you, everybody. Hit our website. Pop onto the AHA Team Training website. go to the resources section, the courses and workshops section. You'll get tons of information. Lastly, do not forget to fill out your evaluation. Get that Duke OneLink account set up if you haven't done that yet. Text that code on the screen, that DUQBES, to the number that you see on the screen within 24 hours. So write it down, pull out your camera, take a picture of the slide here real quick, whatever you need to do to make sure that you get your continuing ed. Okay, that wraps us up for today. Gosh, thank you so much. I want to end this presentation today with how I started it. Dream big and think possible.
Yep.
It's possible. You've just heard two amazing stories that go, yes, barriers, absolutely. Possible to overcome them and achieve a culture of safety and workforce well-being. Oh yes, possible. So thank you so much, and we look forward to seeing you on our next webinar.
Thank you all.